Alright, you're welcome to our program. Today we are discussing emergency preoperative care. So I'll start by defining what an emergency is. So I'll say an emergency is a situation or a condition that poses an immediate threat to human life. Okay, so now I have some aims of emergency preop care. There are a lot of aims, but I've just picked two. Okay, so the first one says to stabilize the patient before surgery. Number two, to prepare the patient for surgery. Okay. In pre-op care, I'll start by admitting the patient. So I admit the patient in a surgical ward, acute bay for close monitoring. I'll admit the patient in a place that has good lighting for easy observation. And I also list the patient in an environment that is clean in order to prevent infections like respiratory tract infection. After admitting the patient, I'll start my resuscitation. So it's resuscitation. So I'll resuscitate the patient following the ABCDE protocol, of which A is airway, B is breathing, C is circulation, D is deformity or disability, E is exposure. So airway, we need to confirm that the patient's airway is open. If the patient's airway is blocked, maybe there's a foreign body, we remove the foreign body. But remember not to put the foreign body further. If there are secretions which suction, the secretion is in order to open the airway. Then you can also open the airway by doing a head tilt or chin lift maneuver. If you are suspecting injury or neck trauma, do not do a chin lift maneuver, you need to do a jaw thrust. So when you are sure that the airway is open, you come to B, which is breathing. When breathing, you need to observe the patient's breathing by observing the rise and fall of the chest. If your patient is having difficulties in breathing, you commence oxygen therapy. On C, that is circulation. That's where you need to check the pulse of the patient. You can also check the blood pressure. You also need to cannulate the patient with a large bore cannula for fluid resuscitation. That's why you can also check if the patient is actively bleeding. You can arrest hemorrhage by applying direct pressure. You can do wound packing. You can also do a tourniqueting or pelvic binding in order to arrest hemorrhage. Then on D, that's why you can also assess the patient level of consciousness using a Glasgow Coma Scale or an ABPU. So you can also check the random blood sugar and act accordingly. Then E, that's why now we expose the patient in order to identify problems that were not identified during the initial assessment. Then after resuscitation of the patient, we come to psychological care. As you know, surgery is a very stressful event, so a patient needs to understand that encourage. So explain the condition of the patient in order to promote understanding. After explaining the condition of the patient, you also explain the procedure that the patient will undergo in order to promote understanding. You also explain the investigation to be done in order to gain patient's cooperation. If there is a patient who underwent a similar procedure that this patient is supposed to go, you can also involve that patient in order to gain patient confidence. So after explaining the procedure and the condition of the patient, you come to consent form signing. This is where now a patient will legally allow you to do the procedure on him or her. So after when signing a consent form, the patient will sign. If he's above 18 years, the patient will sign. If the patient can't sign, you use the fingerprints of the patient of the right thumb. If the patient is under 18 years old, the parents or the guardian can sign on behalf of the patient. After consent form signing, you come to investigation. So that's why now we collect blood for HB or full blood count to know the hemoglobin level and also act as baseline data. We also collect the blood for cross-match, which will help us to know the blood group of the patient in case blood transfusion is needed during surgery. You can also do an X-ray or a scan depending on the condition. Then we come to physical preparation. That's where we wipe the patient body to clean the patient. That if the patient is excessively dirty. Remember, you cannot do a bed bath since this is an emergency. Then you also shave or trim the patient. Then you remove the dentures because the dentures can also block the airway in case intubation is being done. You remove the patient rings in order to prevent electrocution in case a diathermy is used. You can also remove some nail polish in order to observe in case the patient becomes cyanotic. You can also catheterize the patient in order to keep the bladder, urinary bladder empty. Then on observation, you come to observation, that's where now we check the vital signs such as temperature, pulse, respiration, and blood pressure. These will act as baseline data. You can also do random blood sugar. Then on nutrition, you come to nutrition, that's where now we keep the patient neope oral until the patient is taken to theater. You also insert a nasogastric tube in order to empty the gastric content. This will help to prevent aspiration during surgery. Then we come to pre-medication. That's where now we administer prescribed medication. And remember, you cannot give oral drugs because this patient is new oral. Then you come to gowning. That's why you provide the patient with a clean hospital gown and remove personal clothing. Then you come to identity. This is where now you place an identity band on the patient. You can either put it on the forehead or on the arm. So on the identity band, that's where you put the name of the patient, the age of the patient, the sex of the patient, the diagnosis of the patient, the procedure that is supposed to be done, even the ward where this patient is coming from. All these are done in order to have an identity of the patient. After that, now we come to escorting the patient and the handover. This is where now we need to gather all the patient's documents. These include the drug chart, the file, the lab results, even the x-ray if it was taken. So now you escort the patient, you transfer the patient from the ward to theater. From there, you hand over the patient to the theater nurse. After handover, that's when now you come back to the ward, make a post-op bed in preparation for post-operative care. Until next time, bye-bye.